Good afternoon, students. Today I'll be discussing about therapeutic drug monitoring, which we missed in the last week. So, what is therapeutic drug monitoring? Therapeutic drug monitoring, or commonly abbreviated as TDM, it refers to the individualization of doses by maintaining plasma or blood drug concentration within a target range. So this target range is also called a therapeutic range or therapeutic window, which you have already dealt with in your general pharmacology classes. So it refers to individualization of doses by maintaining a plasma or blood drug concentrations within a target range. This is what we mean by therapeutic drug monitoring. So when do we need? There are two major sources of variability between individual patients in drug response. First is dose and plasma concentration. Like you give a particular dose and the plasma concentration is not the same in all the patients. This is called pharmacokinetic variability, and the drug concentration in the receptor and the response. Suppose the same level is there, but the response is variable. This is called pharmacodynamic variability. So these are the two sources of variability in individual patients in drug response. So for which drug is monitoring helpful? So the characteristics of drugs which make them suitable or make them require therapeutic drug monitoring are: first is marked pharmacokinetic variability. That means the response, the amount of drug given and the plasma levels, there is marked variability. The concentrated and there is concentration related therapeutic or adverse effects. Certain drugs, they will have concentration related effect, whether it's a therapeutic effect or whether it is adverse effect. So for certain drugs, if we see a toxicity, we might need to do a therapeutic drug monitoring. For drugs which have narrow therapeutic index, so we need to do a therapeutic drug monitoring for drugs with narrow therapeutic index because we want to obtain a therapeutic range and not a toxic or subtherapeutic range. And for drugs which have defined therapeutic or target concentration range, and for drugs for which the desired therapeutic effect is difficult to monitor. See, certain drugs, particularly drugs for which we normally give for prophylaxis, we do not know whether the desired therapeutic effect is achieved or not. So for such drugs, we may have to do a plasma level monitoring or therapeutic drug monitoring. So if the clinical effect can be readily measured, for example, heart rate or blood pressure, it is obviously better to adjust the dose on the basis of the response. So for these drugs, we do not need to do a therapeutic drug monitoring. We can easily measure a blood pressure or a heart rate or even blood sugar levels. So if the clinical effect can be easily measured, then we can adjust the doses based on the basis of the response. For drugs which we cannot measure the clinical effect readily, then we may need to do a therapeutic drug monitoring. So these are the drugs for which we do not need to do a therapeutic drug monitoring, like antihypertensive drugs or anti-diabetic drugs or drugs which affect the heart rate. So where this cannot be done, therapeutic drug monitoring is useful in two major situations. First is drugs used prophylactically to maintain the absence of conditions such as seizures, cardiac arrhythmias, depressive or manic episodes, asthma relapses, or organ rejection. So most in such conditions, drugs are used prophylactically. After the attack, the drugs are used prophylactically to maintain the absence of the condition. For example, after seizures, we have to maintain continue the drug for a long period of time to maintain the absence of seizures or cardiac arrhythmias, or even in depressed or manic patients, or in case of asthma patients or patients who have undergone organ transplantation to avoid organ rejection. So in such cases, we may need to do a therapeutic drug monitoring. And the second is to avoid serious toxicity, as with aminoglycoside antibiotics, which unlike most antibiotics have a narrow therapeutic range. So many drugs which have with a narrow therapeutic range and serious toxicity, we will need to do a therapeutic drug monitoring to maintain with that therapeutic window. So these are the major two indications for therapeutic drug monitoring. So what is TDM? It is estimating the level of drugs to determine the most effective dose and or to avoid toxicity. So we have to determine the most effective dose for that particular patient, and in a way we have to avoid toxicity. So for example, phenytoin or antihypertensive drugs, we may have to titrate the dose as per the response. So in case of antihypertensive drugs, we measure the blood pressure, but in case of anti-epileptic drugs, for instance, to maintain the absence of seizures, like for instance phenytoin or valproate or any other drug, has to be maintained in a therapeutic range. So to maintain the most effective dose or to determine the most effective dose, we will need to do a therapeutic drug monitoring. And many drugs which are of narrow therapeutic index will have the toxicity when they are in a range above the normal range or the therapeutic range. And so to avoid toxicity, we will need to do a therapeutic drug monitoring. So the drugs with narrow therapeutic window. So this is the range, the toxic dose and the subtherapeutic dose. So below this, the drug is not effective, and above this, the drug becomes toxic. So for drugs which have narrow therapeutic window, we will need to do a therapeutic drug monitoring. For those with drugs which have a wide therapeutic window, we may not need to do a therapeutic drug monitoring. For example, drugs with wide therapeutic window include penicillins, benzodiazepines, anti-ulcer drugs, vitamins, and many other drugs. So certain drugs which have narrow therapeutic window, like anti-epileptic drugs, certain anti-cancer drugs, many immunosuppressant drugs, and anti-diabetics drugs, like, though we do not know a therapeutic drug monitoring for anti-diabetics because we measure the blood sugar, but for all these drugs we may need to do a therapeutic drug monitoring. So these are some of the examples of drugs which have narrow therapeutic window. So what are the information required whenever you do a therapeutic drug monitoring? First is time of sample in relation to the last dose. So we have to know whether the sample that we received in the lab is a trough sample or a peak sample. So the time of sample in relation to the last dose is very important, because your inference will also vary depending on the time of the sample in relation to the last dose. The drug may be at a higher concentration or a lower concentration depending on the time of sample in relation to the last dose. Second is duration of treatment with the current dose. It is very important to know the duration of treatment with the current dose, because for all the drugs, it takes certain time, at least around 4.5 half-lives, to come to the steady state level. So before that, the interpretation of the plasma levels may be inaccurate. So we always advise the therapeutic drug monitoring to be done at the steady state level and not when it is before the attainment of the steady state concentration. We also need to know the dosing schedule. The age and gender of the patient is also required, because the levels may vary as per the age as well as the gender. Any other drug therapy, because there can be chances of drug interaction, drugs which may alter the levels of that particular drug of interest that you are measuring. So we have to know any relevant drug interaction or any other drug therapy. Relevant disease states. Certain disease may alter the physiology as well as pathology of the body, and so we will also need to know the relevant disease state in which the patient is there. And the reason for request, for example, whether it is a lack of effect, or is it just routine monitoring, or is it suspected toxicity. So all this information should be given in the form whenever you require a therapeutic drug monitoring to have better interpretation of the results of the therapeutic drug monitoring, or results of the range that we obtain after therapeutic drug monitoring. So why monitor plasma drug concentrations? First of all, we have to avoid the toxicity. Secondly, we have to optimize the dose or the therapeutic response. We have to detect changes in the pharmacokinetics. If so, there may be change in the pharmacokinetics of a particular drug with change in condition of the patient, and sometimes we need to monitor compliance. For example, drugs which are to be taken for a long time to maintain the absence of the disease, or sometimes even in antitubercular drugs, sometimes we need to measure the levels of the antitubercular drugs to monitor compliance, because the patient stop taking, and so once they stop taking, there can be drug resistant tuberculosis, or there can be emergence of other complications, and so sometimes we have to do a TDM just to monitor compliance also. So what is the first principle of TDM? Knowledge of serum concentration is most helpful when the drug in question requires individualized dosing for optimal efficacy, and more routine measures of therapeutic success are unavailable. So when we need to individualize the dosing for optimal efficacy, then TDM is required. And when we do not have more routine measures of therapeutic success which can be measured, for example, blood sugar levels or blood pressure, for instance, if they are not available, then we will need to do a therapeutic drug monitoring. So we have to have knowledge of what is the therapeutic range, what is the toxic range of all the drugs for which we are doing a therapeutic drug monitoring. So these are examples of drugs with high therapeutic index like NSAIDs, the sedative hypnotics like benzodiazepines. That's why we don't do serum level monitoring of benzodiazepines. Most of the antibiotics, apart from aminoglycosides, we do not do serum therapeutic drug level monitoring, beta blockers. But there are certain drugs which have low therapeutic index like lithium, which is used in manic depressive psychosis. The anti-epileptic drugs, most of the anti-epileptic drugs, including phenytoin, carbamazepine, sodium valproate, phenobarbital, all these have neurotherapeutic index. Some antibiotics, particularly the aminoglycoside antibiotics like gentamicin, amikacin, and even glycopeptide antibiotics like vancomycin, they have low therapeutic index. Digoxin is a drug for which we routinely used to do therapeutic drug monitoring because it has low therapeutic index and immunosuppressant agents. Because in immunosuppressants, mostly we have to maintain that the organ rejection is averted, and so we have to measure the do the therapeutic drug level monitoring of most of the immunosuppressant drugs, and at certain high level they become very toxic. So this is how the drug affects the drug in the plasma drug levels. So first, after you give the drug, there is a peak concentration and then it starts going down. After certain phase, there will be a steady state concentration after repeated administration. So suppose, for instance, this is one drug A. So with repeated dosing, day 1, day 2, day 3, and after 4.5 half-lives, the peak and trough levels will come within the therapeutic range. So we do not want that a plasma drug sample or a therapeutic drug monitoring should be requested at these stages when the steady state level, or at these stages when the steady state level is not reached. So when the steady state level is reached, then normally we ask for a trough sample. So this is it falls within this range, and even the time of dosing is important, whether when you are giving this sample or this sample, it is different, and so you have to have the time of the sampling in relation to the dose is also important, even within the steady state concentration. So there are different methods of Tdm, doing Tdm or therapeutic drug monitoring or measuring the plasma drug concentration, whether it's HPLC or radioimmunoassay or fluorescent polarization immunoassay, enzyme multiplied immunoassay, or clone enzyme donor immunoassay techniques. So these are the different methods of Tdm which you can use depending on the facility that you have. So radioimmunoassay, fluorescence polarization immunoassay, enzyme multiplied immunoassay techniques, and clone enzyme donor immunoassay. So depending on which machine you have and the machine which technique the machine is using. For example, some autoanalyzers will be using FPIE or fluorescence polarization immunoassay technique, or CDR, clone enzyme donor immunoassay techniques, or enzyme emit assay, enzyme multiplied immunoassay techniques. So depending on which machine you have, so different techniques are used. Some of the examples of drugs which require therapeutic drug monitoring include theophylline, which is a bronchodilator used in bronchial asthma. The therapeutic range is 5 to 20 microgram, and it becomes toxic at levels more than 20 microgram per ml. So the patient may experience nausea, vomiting, diarrhea, stomach pain, headache, insomnia, and tachycardia when the levels go above 20 microgram per ml. And at levels above 35 microgram per ml, there can be seizures or cardiac arrhythmias, and so you have to maintain the level within 5 to 20 microgram per ml for theophylline. Another example is gentamicin or tobramycin, which are aminoglycoside antibiotics. They have a therapeutic range of 5 to 10 microgram per ml, and more than 15 microgram per ml, they can result in ototoxicity and nephrotoxicity, which are the toxic effects of the aminoglycoside antibiotics. Digoxin improves cardiac output in CHF patients. It is highly bound to tissues, and the therapeutic, digoxin is a drug of with high volume of distribution. The therapeutic range is 0.8 to 2 nanogram per ml. The toxic level becomes when it is more than 2 nanogram per ml, and it can produce arrhythmias, GI, and CNS symptoms. Carbamazepine is an anti-epileptic drug and also used for the treatment of trigeminal neuralgia. It is also active in tonic-clonic generalized seizures. The therapeutic range is 4 to 12, or some books say 6 to 12 microgram per ml. Toxicity occurs in 1/4 of the patients include diplopia, drowsiness, nystagmus, ataxia, nausea and vomiting, and also there can be dermatological, hematological and hepatic toxicities. So the range is 4 to 12 or 6 to 12 microgram per ml, and above 12 or above 16 it can result in side effects. So these are the therapeutic range of certain antiepileptic drugs, like carbamazepine is 4 to 12 microgram. You might have already done in your drugs when antiepileptic drugs. They are mostly drugs of neurotherapeutic window, and carbamazepine above 12 microgram it becomes toxic. Valproate is 50 to 100 microgram per ml, and more than 150 microgram per ml it becomes toxic. Phenobarb is 15 to 40 microgram per ml, and more than 60 it becomes toxic. And phenytoin is 10 to 20 microgram per ml, the therapeutic levels, and with more than 20 microgram per ml, the toxicities can occur. So phenobarbital, as I told you, is an anticonvulsant drug. It's a long-acting barbiturate. The therapeutic range is 15 to 40, and the toxic symptoms appear at more than 60 microgram per ml. Drug interactions are also common with phenobarbital because it causes induction of hepatic microsomal enzymes. Phenytoin, most frequently prescribed anticonvulsant. The therapeutic range is 10 to 20 microgram per ml, and toxicity occurs when it is more than 20 microgram per ml. So patients, when you are sitting in an OPD and a patient comes to your OPD with nystagmus or ataxia, he is not able to walk properly and he complains of blurred vision or drowsiness or coma, you can think that the patient has gone into the toxic range, and you may have to reduce the dose of the phenytoin in that patient. So this is very classic of phenytoin. The patients come to your OPD with nystagmus, ataxia and blurred vision, and so in such patients you should always go for measuring the plasma drug levels of the drug, that is phenytoin. Valproate acid is broad spectrum anticonvulsant but mostly used for absence seizures, and it has also therapeutic range of 50 to 100 microgram per ml. It is hepatotoxic, and so you have to do, apart from the routine serum levels, you also have to do the liver function test in case of routine periodic liver function test for patients who are on valproic acid. So why monitoring is important for AD? Because with high doses or with high plasma levels, there can be serious side effects. Phenytoin can result in arrhythmias, valproate can result in hepatotoxicity, and carbamazepine neurotoxicity. And moreover, in epilepsy, polytherapy is very common. You will hardly see a patient who is on a single monotherapy with a single antiepileptic drug. So there can be polytherapy with other drugs. For example, like phenytoin can be prescribed with some other drugs of valproic acid, carbamazepine, phenobarb, and there can be other drugs also, like an epileptic patient may also be suffering from tuberculosis, or he may also have diabetes, or the patient may be on oral contraceptives because we advise the patient not to become pregnant while on anti-epileptic drugs, or any other drug. So there can be AED interaction, anti-epileptic drug interaction with the other anti-epileptic drug, or AED, anti-epileptic drug and other drug, whichever condition the patient has and whichever drug the patient is having. And so you have to take into consideration the polytherapy in case of epilepsy also while monitoring the plasma levels. Another very important group of drugs for which we do therapeutic drug monitoring are the immunosuppressants, because they have narrow therapeutic index. Most of the immunosuppressants, they have narrow therapeutic index, and if the immunosuppressants go into the subtherapeutic range or the subtherapeutic level, there are chances of acute rejection episodes. So we have to avoid that, because after transplantation the patients should not undergo acute rejection episodes, and so we may need to do a therapeutic drug monitoring. Most of the drugs, they are nephrotoxic, and so to avoid nephrotoxicity we may have to do a therapeutic drug monitoring. And in a way this can result in decreased drug cost, because most of these drugs are very expensive. So if you give a proper dose, then we may decrease the dosing, as well as we may need to avoid the toxicity. So this will result in decrease in drug cost, and it is safe and feasible. So most of the immunosuppressant drugs we may need to do a therapeutic drug monitoring. So therapeutic failure results when either the concentration is too low, resulting in ineffective therapy, or is too high, producing unacceptable toxicity. Between these limits of concentration lies an associated with therapeutic success regardless of therapeutic window. So if you are giving a subtherapeutic dose, or if the drug is in the subtherapeutic range, it will result in therapeutic failure. And even toxicity is regarded as therapeutic failure. If you go above the therapeutic range, then there will be toxicity, and so this also results in therapeutic failure. And so to obtain the therapeutic success of many drugs, you may need to do a therapeutic drug monitoring, because we want the levels to lie in this margin between the subtherapeutic level and the toxic effect. So plasma concentration of a drug must correlate quantitatively with both the intensity and probability of therapeutic or toxic effects. For such drugs, we need to do a TDM when the concentration correlates quantitatively with both the intensity and probability of therapeutic or toxic effects. So if it is a direct correlation between the concentration and effect may be insufficient grounds for plasma level monitoring if the therapeutic effect is easily monitored. For instance, I told you about the anti-hypertensives, anti-diabetics. It is most relevant when the objective is to maintain a therapeutic effect by maintaining a concentration within a limited range, and when the likelihood of toxicity can be predicted from the concentration. So when such a drug, then we will need to do a therapeutic drug monitoring. It is also important with narrow therapeutic window when therapeutic failure is likely, and those adjustments can often be anticipated based on the patient's age, weight, clinical status, especially if there are renal, hepatic, and cardiovascular functional abnormalities. So even after accounting for these factors, sufficient uncertainty often remains in patient-specific or individual kinetics of the drug to warrant plasma concentration monitoring. So some drugs we need to do a plasma level monitoring. So drugs for which there is difficulty in measuring or interpreting the clinical evidence of both therapeutic or toxic effects. For example, nausea and vomiting occur in both high distilling toxicity as well as congestive heart failure. So we don't know whether it is a therapeutic failure or whether it is a toxicity. So in such cases, we may need to do a therapeutic drug monitoring. For instance, phenytoin toxicity can occasionally cause an increase rather than a decrease in the frequency of epileptic seizures. So, if a patient comes back to your OPD with an increase in seizure episodes, so it can either be a toxicity of phenytoin with high levels of drug in the blood, or it can be a therapeutic failure because the drug is not effective, and that's why you are seeing an increase in the frequency of epileptic seizures. So, it can be both an increase, both a clinical evidence of therapeutic or toxic effect. Renal failure occur in patients with gram-negative septicemia because of the disease or because of the adverse effects of gentamicin used to treat it. So, both the therapeutic failure can cause renal failure, as well as the drug side effect toxicity of the drug can cause renal failure. So, when there is the toxic effect and the therapeutic failure, it is difficult to judge. So, if the relationship between the plasma concentration of a drug and its adverse effect is known, it can be used to distinguish between the drug-induced and the disease-induced effects. So, in such cases, we will definitely need to do a therapeutic drug monitoring. So, drugs with steep dose response curve, for which a small increase in dose can result in marked increase in desired or undesired response, for example, theophylline. So, if there is a steep dose response curve, then we can also need to do a therapeutic drug monitoring. And drugs for which Tdm might not be indicated include those characterized by wide therapeutic index, or for those for which response can be easily monitored by clinical signs. Pharmacokinetic factors that can cause variability in plasma drug concentrations include drug-drug interactions. So whenever you give Tdm sample, you have to mention the other drugs also, so that there can be less difficulty in interpreting the plasma levels. The patient disease state, whether the patient is having any renal dysfunction or hepatic dysfunction, or even the age and sex of the patient. Physiological states such as age, weight, sex can also cause absorption variation, as well as there can be alterations in their physiology. And differences in the ability of a patient to metabolize and eliminate the drug is also important. So all these factors should be taken into consideration while interpreting the results of any plasma level monitoring. So whenever you have a report with you, you have to consider all these factors before giving your interpretation. So whenever you are measuring or monitoring compliance, so what is compliance? It is the extent to which the patient follows a prescribed drug regimen. The extent of compliance can vary from 10 to 92%, and the compliance decreases with chronic diseases or for those drugs for which we have to give for maintenance or to maintain the absence of diseases. So factors which affect compliance are the nature of the treatment. The complexity of the prescribed regimen can also affect the compliance. So if the regimen is very, very complex, patient may delete or stop taking some of the medications. And suppose the drug is associated with adverse effects, then there can also be decreased compliance. The characteristics of the patient. Certain patients are inherently more compliant than other patients who are inherently less compliant. They think that now my symptoms have improved, I do not take the medicine or something like that. So it all depends on the patient's outlook also, and the behavior of the doctor. How much influence the doctor can stress on the importance of continuation of the medication to the patient is also important in affecting the compliance of certain medications. So how you influence the patient to continue the prescribed medicine as per prescription is also very important in improving the compliance of the patient. What are the samples that we can take? The most common sample that we give for therapeutic drug monitoring is a blood sample. So this is most often used for other medical legal cases also. It is useful in case of paracetamol, salicylates, carboxyhemoglobin, methanol, ethylene glycol. And most of the samples that we give for therapeutic drug monitoring, it is all mostly plasma or serum. So we have to take the blood samples. The disadvantage with blood sampling is that it is invasive, drugs only detected for short time, and analysis of blood is labor intensive and relatively expensive. So you have to have a machinery, you have to have the kits and everything. So it is relatively expensive. So sometimes, in patient of alcohol intoxication, we do the blood alcohol concentration and then we see the patient. This is beyond the scope of your class. Another sample which we can sometimes take but not commonly use is urine. This is performed when the blood concentration of the compound is too low for detection by conventional measures or rapidly eliminated, or if the drug have high volume of distribution, for example, phenothiazines, benzodiazepines, certain antihistaminics or tricyclic antidepressants. But this is not very commonly taken, but this can be used in certain situations as highlighted here. The advantages are that it is readily available. It is obviously much easier to take a urine sample than a blood sample. It is non-invasive. Drugs or metabolites, they tend to concentrate in the urine, and it can be easily handled and analyzed, and the cost is relatively less. But there are disadvantages, like the drugs or metabolites only indicate the past use. It can be subject to adulteration or substitution. So sometimes after the patient takes the urine sample, it can be subject to adulteration, or even it can be subject to substitution. That means the patient can give you somebody else's urine, and there are short detection time. So in an attempt to avoid detection of illicit drugs use, some people are asked to give a urine sample for drug screening. They will attempt to substitute the urine of another person or adulterate the urine specimen using either commercially available adulterants or home brew recipes. So sometimes when you get the urine sample, it may not be an urine sample even. So this is a risk with urine samples. The result interpretation, after you do a therapeutic drug monitoring, the result interpretation is very, very important. You cannot just get a sample and interpret. So while interpreting the result, you have to take certain things into consideration. First, I told you that is the time of sample collection. The time of sample collection is important because when you are collecting the sample, whether it is a peak sample, whether it is a trough concentration, or whether you are taking a sample after the steady state concentration has been reached. So all these are very important. Time of administration of the drug. So just normally we take the trough sample, and so just before the next dose we take the sample. So if you take the sample after the administration of the drug, then it can be a peak sample also. So you have to take into consideration time of administration of the drug. Time of appearance of toxic effects or death should be interpreted in relation to pharmacokinetic parameters of absorption, distribution, metabolism, and elimination. So if there is a toxic effect or death because of toxicity of a drug, then all these points should be taken into consideration. That is the pharmacokinetic parameters of absorption, distribution, metabolism, and elimination. So the indications of Tdm are suspected toxicity. When you think that the drug has reached toxic concentration and you may need to reduce the dose. And sometimes there is lack of response, whether it is the drug is ineffective, whether the drug is not coming to the therapeutic range, or whether we need a change of drug. So for that we need to do a TDM. Particularly for anti-epileptic drugs, before changing to another drug, we may need to do a therapeutic drug monitoring. For assessment of drug compliance with medication regime, particularly drugs with for chronic diseases, sometimes we need to check the compliance. Suppose the patient comes back to you with the same symptoms, and he or she will say that I have been taking the drug regularly. But on measurement of the serum levels, you may see that the patient is not taking at all. So sometimes the patients also lie, and so sometimes you will need to do a therapeutic drug monitoring to assess the drug compliance. For considering change in dosing regimen, before changing any dosing, increasing or decreasing the dose, we may need to do a TDM before we consider a change of dosing regime. Change in the clinical state of the patient, whether the patient is improved or deteriorated, or even the patient has become pregnant, or patient has renal disease or hepatic disease, and any change in clinical state of the patient, we may need to do a therapeutic drug monitoring. And the potential drug interactions. So if you are suspecting potential drug interactions, whether that particular drug has any change, has to do with any change in the serum levels, we may need to do a therapeutic drug monitoring. So the routine levels on controlled non-toxic patients are not indicated because they are very costly to measure the serum levels all the time, and so we don't have to do the routine levels in normal patients. Controlled non-toxic patients. So only when you suspect something, some suspected toxicity, or there is lack of response, or you want to assess the compliance, or there is a change in the dosing regime, or change in clinical state of the patient, or potential drug interactions, only then you should consider doing or sending a sample for therapeutic drug monitoring. So ideally you should do after 2 to 4 weeks after start of therapy, and after you should do on failure on standard dose of the drug, or you suspect a failure of compliance, or when there are adverse effects to the drug, or when other drugs are added. Then time also you may also need to do a therapeutic drug monitoring, or the patient becomes pregnant, or hepatic or renal diseases. So these are some of the conditions for which you might need to do a therapeutic drug monitoring. Sometimes you may also need to do monitoring of pharmacologically active metabolites, and in special risk groups where drug pharmacokinetics is altered. For example, in neonates, before giving certain drugs, you may need to do a therapeutic drug monitoring. Elderly patients, pregnant women, patients with compromised renal functions or hepatic diseases, and suspected drug overdose. For identification of uncommon situation in which overdoses causes increased seizures, so you may need to do therapeutic drug monitoring, whether it is because of therapeutic failure or because of overdoses, and detection of pharmacokinetic interactions which may compromise the adequacy of therapy. So these are some of the indications for which we may need to do a therapeutic drug monitoring. But therapeutic drug monitoring also has certain limitations. So what are those limitations? First is lack of data. Therapeutic concentration and maximum toxic level for each drug have yet to be defined. So even when some drugs are very toxic, we do not know what is the therapeutic concentration or what is the maximum toxic level for that particular drug. And without this, using TDM to adjust doses is meaningless. So when you don't have a defined therapeutic range or therapeutic concentration at which the optimal effect is therapeutic effect is going to occur, so doing a TDM is meaningless. So even if you have a therapeutic range, it may differ as per the population also. So these are some of the information that is required when doing a TDM: the time of sample in relation to the last dose, duration of the treatment with the current dose, the dosing schedule of the patient, the age, gender, and the current physiological status of the patient, other drug therapy, the relevant disease state, and what is the reason for request, like whether it is a lack of effect, routine monitoring, or suspected toxicity, and present or previous drug level, if any. So if the patient has been undergone a therapeutic drug level monitoring before, then that previous level should also be indicated in the form. There can be inter-individual variability also. There can be significant pharmacokinetic variability from person to person and between different individuals. So the same level, for example, phenytoin 10 to 20 microgram per ml. So suppose a patient has 25 microgram per ml. So he may not necessarily have all the symptoms of toxicity with phenytoin. Rather, that may be his therapeutic range. So there can be some pharmacokinetic variability from person to person and between different individuals. The therapeutic or target range should be regarded only as an approximation, and since it is based on data only from a few patients. And even in from that data, there can be inter-individual variability also. And so it should be regarded only as an approximation, the therapeutic or the target range. And some patients have no seizures when their plasma drug concentrations are low, whereas individuals in low, whereas others require concentrations above the target range to be free of seizures. For example, I told you a patient of 25 microgram per ml phenytoin may not have any toxicity, and they may require this level to have the target range. So some patients will have some inter-individual variability. There is also effectiveness limitations like compounding factors. Factors which distort the true effects of the drugs may limit the effectiveness of the drug. So these factors include synergy between classes of drugs, cross resistance among classes of drugs, and relationship between adherence, drug exposure, and outcome. So there are some certain compounding factors which you should take into consideration when doing a TDM. So this is also one of the limitations, and one of the major limitation is these are very, very expensive. Not all the patients can afford, and not all the facilities will have the facility to do therapeutic drug monitoring, particularly in rural areas or remote areas. The machines are not there, the instruments are not there, and the facilities are not there. And so we are not able to do the therapeutic drug monitoring. So difficulty in interpreting interpatient variations due to pharmacodynamics is also there in case of as a limitation. And TDM requires the steady state level of the drug. Means we should do, that means before doing TDM, we have to wait for the drug to attain the steady state levels. So traditional TDM can only be started after drug administration, and so before starting the drug, individualized drug therapy is not possible. So TDM, if you want to do a TDM based drug therapy, then the drug has to be started on a particular dose, and we have to increase or decrease the dose depending on the levels and the response. So individualized drug therapy is not possible with the traditional TDM. And so the rigid one dose fit all approach is a non-traditional TDM approach. So with the non-traditional approach, we measure the area under curve is an example of non-traditional TDM, and therapeutic range for most anti-cancer drugs is not established, and so we measure the AUC of the drug. And sometimes we may need to do a pharmacogenomics as a tool for TDM. So there can be genetic polymorphisms, pharmacokinetics, and there can be pharmacodynamic variations, and diagnosis of prevention-related approach by pharmacogenomic guided TDM. For example, with carbamazepine, certain HLA subtypes are more prone to toxicity with like the Stevens-Johnson syndrome associated with carbamazepine. So that is only with certain genetic HLA types that we see such toxicity. So we may need to do a genetic polymorphism studies in such patients. So interpretation of pharmacogenomic results does not need steady state of the drug. So pharmacogenomic is already there. So you do not need a steady state of the drug, and pharmacogenomic protocols could be non-invasive. Sometimes, you can do the pharmacogenomic study from a hair sample or some other sample, and patient compliance may improve markedly. So if you use pharmacogenomics as a tool for doing TDM, the compliance and the thing can improve, the TDM results can improve, but it is very expensive, and not all, as I told you before, it is not there everywhere. So why traditional Tdm is necessary? Because drug levels may be influenced by environmental and genetic factors, potential pharmacokinetic interactions with drugs, other drugs, and the hormonal levels can also affect the drugs. So the pharmacogenomic approach is supportive to traditional TDM. For instance, with carbamazepine, you can do a genetic analysis as well, apart from measuring the therapeutic drug, the serum levels of carbamazepine in such patients. So pharmacovigilance and TDM, therapeutic drug monitoring and pharmacogenomic testing, they enhance the therapeutic response and just helps confirm toxicities and rather minimize the adverse drug reactions. So if you combine pharmacovigilance and TDM, so you may avert certain toxicities, and you can decrease the number of adverse drug reactions. So TDM can also help in decreasing the toxicities. So TDM and pharmacoeconomics. So though the TDM test itself is costly, but it can actually result in decrease in the overall cost to the patient and the society by decrease in the hospital stay, because if you are giving in a therapeutic range with the therapeutic efficacy, by decreasing the adverse effects, then it may result in decreased hospital stay. It can also result in increased efficacy, which will enhance the treatment outcome. So ultimately, it can result in a decrease in the cost. If you have increased efficacy and decreased hospital stay, it may result in decrease in cost to the patient as well as to the society. And this will also result in decreased adverse drug reactions, which will also decrease the overall cost to the patient as well as the hospital. So apart from the conventional drugs that I have told you before in the slides, there are certain other drugs for which therapeutic drug monitoring has been proven to be helpful. For example, the antifungal drug voriconazole, nowadays therapeutic drug monitoring is done frequently. Certain anti-cancer drugs, 5-fluorouracil and other antidepressant drugs, methotrexate, everything is like therapeutic drug monitoring. It has been shown to improve the patient response as well as compliance, as well as avoid the toxicity, and even all those immunosuppressants, antidepressants and quinidine therapy. So overall, TDM is required for drugs with narrow therapeutic index drug, but it can overall, though the test itself is costly, it can overall result in decrease in the cost to the patient and the hospital. So for evaluation of Tdm data, you have to take into consideration the patient characteristics, the age, sex, whether the patient is pregnant, whether the patient is smoking, because smoking can also alter the blood levels of certain drugs, the height and weight of the patient, the primary disease process and any concurrent disease process. The laboratory data that should be taken into consideration include the renal functions, the hepatic functions, the protein functions. The specimen information is also very important, like the time of collection, the nature of the specimen, whether it's a blood or urine, and the drug information should also be there. The name of the drugs to be assayed, the brand or the generic name. It has been seen particularly in anti-epileptics drug that with the change of brand, the levels can also vary. So the brand and the generic name is also sometimes important. The time of the last dose, the frequency of the prescribed dose of the particular drug, the dosage form, route of administration, and concurrent drug therapy to take into consideration the drug-drug interactions. And the purpose of assay and urgency of request should also be there, like whether it is for therapeutic confirmation, to see the suspected toxicity, or in case of drug overdoses, or to monitor the active metabolites or suspected drug interactions, or when there is an absence of therapeutic response. So what is the purpose of assay and what is the urgency of the request? So if it is for drug overdoses, then you may need to do it urgently. But if it is just for monitoring compliance or to see the absence of response or therapeutic confirmation, then you may need to wait. You may do it like, because many of these kits, they have to be done together. Like when you have a sample of 10 samples for that particular drug or 100 samples. So if you run at together, the cost becomes less. And so sometimes you may wait, or sometimes you may do urgently only for that particular single sample if it is a drug overdose or toxicity request. So purpose of the assay and urgency of the request should also be there in the TDM request. So what are the benefits of TDM? You can establish a therapeutic relationship. Drug levels are linked to epileptic effect, and plasma concentration significantly contribute to drug's therapeutic response. And so you can do a therapeutic relationship by doing a therapeutic drug monitoring. It can also result in improved effectiveness, particularly anti-epileptic drugs enhance anti-epileptic activity and prevent individuals from failing therapy by individualizing and optimizing drug therapy. So it will improve the effectiveness of the drug therapy and the quality. It should have good sensitivity and specificity for the test, and proper TDM may address the variability within one individual. So the same level of phenytoin may be effective in one patient, may be toxic in one patient, or may be subtherapeutic in another patient. And so in that one patient with serial TDM, you can also address the variability in one individual patient. So thus TDM can help to improve seizure control in numerous ways: identification of therapeutic failure due to underdoses, identification of therapeutic failure in the presence of optimal doses, suggesting that a different AED should be tried, and detection of non-compliance with prescribed therapy, which may be responsible for unnecessary and avoidable therapeutic failure. So that's how it can help in improving the seizures. So effective TDM, which should have a good analytical practice, efficient organization of laboratory resources, knowledge of pharmacological and toxic effects should be there, knowledge of basic and clinical pharmacokinetics should be there, interpretation of analytical findings for individual patients, and assist physicians in improving therapy. So a properly done TDM can help in the improving the patient compliance, can result in averting toxicities, and can thus help in improving the effectiveness of the overall therapy as well as the cost. However, you should remember that the clinical endpoints rather than blood levels are the most effective measures of effectiveness of any drug therapy. So TDMs should only help you, but you should always have your clinical judgment. So the clinical endpoints rather than the blood levels are the most important measures of effectiveness of any drug therapy. However, nevertheless, the blood level monitoring is important to help you assess in arriving to the clinical endpoints to measure the effectiveness of any drug therapy. Thank you very much.